Good afternoon and welcome to Webinar Wednesday. We're excited to have over 370 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday t-shirt for answering this trivia question. May is National Salad Month, spinach being one of the most popular salad leaves. Which famous cartoon character made spinach popular? Answer now using the questions feature on your dashboard. While you're answering, I just want to remind everyone that if you've missed any of our previous webinars, you can watch them on our website, webinarwednesday.live, and you can still receive your CE credit as well. Okay, let's see who the winner of our Webinar Wednesday t-shirt is, and it is Brian Bideman. Congratulations, Brian. Of course, the correct answer is Popeye. Webinar Wednesday would like to thank our sponsor, Nuvolo. Nuvolo helps companies better manage enterprise assets using modern mobile real-time reporting and an industry-leading cloud-based platform. Visit nuvolo.com for more information. Our facilitator today is Heidi Horn, VP of Global Enablement at Healthcare at Nuvolo. Heidi has over 20 years of experience in the healthcare technology management industry, and she was the 2019 recipient of Amy's HTM Leadership Award and is well known for her transformational work leading SSM Health's 120-person HTM department for more than a decade. Heidi is also heavily involved with Amy and serves as a member of Amy's board of directors, as well as chair-elect of Amy's Technology Management Council. Heidi is also an award member of the Amy Fellow Program. Heidi, you may begin whenever you're ready.
Okay, thank you, Linda. Well, first of all, congratulations, Brian, on your auspicious award there. We have a really great panel today, and I am really pleased to introduce them. And I did want to take a few minutes just to give you a quick background of all of our panelists so you know the wealth of knowledge that they will be sharing with you. So panelists in this webinar representing the healthcare technology management field are as follows. Mike Busdicker is a System Director of Clinical Engineering Shared Services at Intermountain Healthcare based in Salt Lake City, Utah. Mike started his career with the United States Air Force and as a 1983 graduate of the DoD Biomedical Equipment Repair School. His total military service included 7 years of active duty and 20 years with the Wisconsin Air National Guard. During his military time, he completed an operational deployment to Iraq and achieved the highest enlisted rank of Chief Master Sergeant. Prior to his employment with Intermountain, he has held leadership positions with Service Master Management Services, Airmark Clinical Technology Services, TriMedics Healthcare Services, and Alexian Brothers Healthcare System. Mike is an active member of numerous industry associations, including ASHI, HIMSS, and AMY, and is a member of the AMY Technology Management Executive Council. Danielle Cowgill is a currently manager of clinical engineering and biomedical engineering at Stanford Children's Health in the Northern California area. Previously, she has held roles as clinical and systems engineer at both Stanford Children's Health and with Kaiser Permanente. She's been involved in lifecycle management, capital planning, integration projects, operational efficiencies, and CMMS deployments. Bill Mannis, National Director of Technical Services at Agiliti, has oversight over Agiliti's nationwide Center of Excellence. These ISO certified technical service centers are staffed with specialty service engineers that support Agiliti's 80+ district service centers, medical healthcare facilities, the government, original equipment manufacturers with depot and field services. Bill has over 34 years of experience in the medical equipment technical services field, starting as a field service technician supporting respiratory and blood gas analyzer equipment. Throughout his career, he has held various technical management positions at the divisional, regional, and national levels. Moving on to our Healthcare Facilities Department panelists, they are as follows. John Ellis, System Director of Facilities at Intermountain Healthcare, is a certified healthcare facilities manager and a Lean Six Sigma Black Belt. He oversees the operations, maintenance, and energy management of 24 hospitals and 250 clinics in Utah, Idaho, and Nevada. John is a veteran of the U.S. Army and Utah National Guard. His career in facilities covers more than 20 years and includes experience in higher education, manufacturing, and healthcare facilities leadership. Bob Mulcahy is Vice President of Facilities for the Southern region of Hackensack Meridian Health based in New Jersey. Bob also works as an intermittent life safety code surveyor with the Joint Commission. Bob has demonstrated leadership and delivered facility and safety improvement in the healthcare space for over 20 years. Before coming to Hackensack Meridian Health, he served as Vice President, Chief of Facilities Operations and Support Services for St. Peter's Healthcare System in New Brunswick, and as Assistant Vice President of Facilities, Northern Region for Barnabas Health. And finally, our IT panelist is Joyce Smith, whom I had the pleasure to work with for several years. Joey is a cybersecurity professional who has spent the past 4 years working in the realm of medical devices and operational technology cybersecurity for a number of healthcare delivery organizations. He is currently a cybersecurity specialist for operational technologies at the Cleveland Clinic and continues to be involved in industry efforts to improve the security of medical devices. So thank you for giving that opportunity to introduce all of our panelists, and as you can see, we have a wealth of information between all of them. So I just want to let you know I am going to be jumping off. This is a Q&A session with these panelists, and I'll be kind of moving around between the different panelists and asking them different questions about not only the COVID-19 pandemic, but also how they are planned to be working with other departments, IT, facilities, and HTM as they move forward. So I'm going to kind of kick it off with a general question to the whole panel. And this is, revolves around the COVID-19 pandemic. Can you please give us some specific examples of how your department has had to plan and collaborate with the other two departments represented on this panel in response to the COVID-19 pandemic? What were some of the challenges working across departments, and how did you overcome them? Who would like to take that one?
So Heidi, this is Mike Busdicker. And I'll just cover a couple real quick and give others an opportunity as well. But as we started looking at the COVID-19 and some of the challenges that we were anticipating that we were going to face within our organization, we had to come together with other departments like facilities management, with IT cybersecurity, as we started looking at expansion projects for whether it's ICU or standard patient beds within our facilities. And again, with 24 facilities across the organization. So in working with facilities, you know, we had to address certain things like facility connections for equipment like air suction, O2, impact on facilities like HVAC with equipment moving into expansion spaces. On the IT cybersecurity side, of course, network connection, EMR data, updated equipment, you know, and things that are going to be connected across the system. And I don't know that we really had any significant challenges as we worked with those departments. It was just ensuring that we had the right people, right places, and that everyone was working for the same result. And also, I think one of probably the biggest things that we encountered initially in working through it was individuals working or facilities, our organizational facilities like our hospitals working independently or in geographic areas instead of one single team. So we had multiple requests for data and information coming from multiple sources. And once we got that down pat from a incident command logistics section to where information was coming from one source of truth and going out to the state or the government, the federal government, or wherever we wanted to send it, then things really smoothed out for us.
Hey, thanks, Mike. Would anyone else like to answer that question?
This is Joey. I can answer it. Sorry, but I kind of want to tack on to what Mike said, because a lot of what we're doing what we've done at the clinic echoes pretty much exactly what Mike said. To give my perspective on what we've done on the security side, a lot of our efforts have been to expedite some of our more the risk assessment processes. So with a lot of COVID expedited a lot of initiatives we had underway at the clinic, and some of those initiatives included things like portable ultrasonography for immediate diagnosis and things like that. And because of COVID, we've had to expedite those projects and push them through our standard IT processes as part of not just security assessments, but also IT onboarding assessments to make sure that they actually implement into our infrastructure properly. So the challenge there that we've encountered has really just been trying to make sure that we can get a rapid turnaround on these initiatives down to days instead of the weeks that it would normally take. And that's been a challenge, not just internally, but also sometimes even with vendor engagement, because we're definitely not the only provider organizations asking these same questions.
Right.
Hey, I'll jump in here. It's Bob Mulcahy. Being in New Jersey, we kind of were forced on the fly to make adjustments to our ICU capacity, and the coordination between IT was essential to really make sure the areas that we were surging to. Our surge plan really was based around patient regular med surge type of plan, but it really became an ICU surge plan. And then do we have the capacity IT wise to handle what we're moving into those areas, from IP drops to whatever we have on the Wi-Fi, to make sure that we're going to be monitoring and retrieving data properly through the IT systems was a big challenge. And it just continued to grow as the pandemic worsened day by day. It seemed like we were fitting out another area for ICU capacity. So a lot of integration between the two departments, and it was absolutely essential that we, we're kind of just making it up every day that we're moving along. It was a little intense.
Yeah, I bet, Bob, since we're talking and you were mentioning it, so how have things changed over the, from the beginning of the pandemic to where you are now in the New Jersey area?
Well, things have flattened out, definitely. Our numbers have gone down. We still have, a lot of ICU admissions, but they've flattened and kind of lessened out. And we're looking at what is it going to mean to get back to regular business right now, and what does that mean? What are we going to dismantle? What are we going to keep in place for the second wave? Because we feel it's definitely going to happen. And can we actually leave some of the systems in place that we've built between IT and facilities as we, kind of scale back and get back to normal business? And then on top of that, we're looking at a pure directive of, you hate to say clean and dirty, but I'll use those terms, between COVID and non-COVID areas, and how can we segregate that out and separate it out from all different sides of the spectrum. So a lot of things happening every day, and it changes every single day.
Okay. Danielle, this question is for you, actually. So when the novel coronavirus was first identified, children were largely thought to be unaffected by the disease. What was HTM expected to do at Stanford Children's Health during those first few weeks of the pandemic? And has anything changed in your priorities and strategies for that? For example, you had mentioned a few weeks ago that you thought you would be taking more of a supporting role in getting prepared to accept adult patients. Did that happen? And how did things change? And then how closely did you need to work with the facilities in IT in your planning for COVID-19?
Hi, Heidi. So yes, children luckily were not as affected by this pandemic as adult patients were. So fortunately for us, we were able to take more of a support role. In California, most of the hospitals do take care of both pediatrics and adult patients. So we did prepare for receiving adult patients as well as pediatric patients from other hospital organizations. So in order to do that, we did work very closely with other hospital groups, both with their IT and facilities, including our own, in order to prepare rooms, maybe that were designed for pediatrics, but could be flexed for adult patients. We also worked with nearby hospitals to prepare for sending them equipment in case they needed some of our supplies, such as ventilators, to take care of their patients.
Okay, great, thank you. Bill, this question is directed to you. As an independent service organization and a supplier of rental equipment that is in high demand during this pandemic, please explain how your organization has needed to respond. Since your HTM technicians are not official hospital employees, have you found it challenging to work closely with the hospital's IT and facilities departments? And can you also explain why or why not? Thank you.
Sure. Well, we put a lot of effort into making sure our employees had the proper PPE, and then we worked to put in new guidelines to ensure both our employees and customers' safety. And we definitely continue to collaborate with our customers on several fronts, technical services, logistics, and asset management, and of course, the rental equipment. With the technical services, we've assisted with the preventive maintenance and repair of the customer-owned equipment. And then with the logistic and asset management, what we're really doing is making sure that the customer-owned equipment is patient-ready and getting it to where it's needed in the facility so that the healthcare providers can spend more time with their patients. One of the unique things that we've been doing is helping local government agencies with the setup of these surge facilities that you've heard about, like in convention centers, field houses, et cetera. And then, what we've been doing is making sure the delivery as well as the setup of the testing of that equipment. And then with rental equipment, with us having over 85 service centers and over 400,000 assets in our rental fleet, we're very good at getting the equipment to where it needs to be and being patient ready. So our logistics team's been very diligent with tracking the COVID hotspots and ensuring the equipment is in the areas where it's needed most. And then we've also put in some guidelines to prevent hoarding of equipment. But we're not only working with individual facilities, we're also working with larger healthcare systems, as well as state and federal government agencies. And then additionally, we've started having strategic meetings with the customers to help them better prepare for the future. As far as your second part of the question about having difficulties working with facilities in IAT, not at all. Agiliti has over 1,300 employees that report and work directly at healthcare facilities every day. And these employees are acting as the biomed department and as well as the asset management team. So in most cases, we're viewed very much as part of the hospital team. And because of this, we have a really good idea of the roles and responsibilities of the various departments. And we generally see that the facility and IT teams appreciate our understanding of their locations, needs, and protocols. So short answer, no difficulties. It's just, a lot of collaboration.
Okay, thank you, Bill. Some of you have brought this up in your answers, but I'm curious, has anyone tried to share clinical equipment between hospitals and your own health system and or outside of your health system?
That's Bob okay. I can jump. I mean, it's Bob okay from Hackensack Meridian. Our network did a phenomenal job of moving ventilators and moving equipment as needed up and down, depending on who was surging and who wasn't. And the great coordination through our command center to make sure everybody had everything they needed when they needed it, and they did an outstanding job. Nobody had any shortfalls.
Yeah, this is Bill Manis. As I would agree with Bob, we're seeing an increase of healthcare facilities sharing equipment. And, we've partnered with some of these facilities to help them with the deployment and tracking and servicing of the equipment at multiple sites. And then we're also seeing a lot of the state agencies with their own stockpiles of equipment and helping them with the setup and testing and then actual delivery of the equipment throughout their state to the local hospitals in need.
Thanks. I heard somebody else also wanting to answer.
Yeah, Heidi, John Ellis. At Intermountain Healthcare, we've not only been able to share and move clinical equipment, but physical plant equipment as well, air scrubbers, negative air machines. We've been able to move to the areas that have needed it most, and then when their use was done, pull them back and redeploy them. So it's been a really nice exercise in coordination.
Right. So
and Heidi,
what sort of tools? Yeah, go ahead.
Oh, I was just gonna piggyback on that real quick, Heidi, and say that some of the things that we've done here at Intermountain as well is, as we started looking at things, we started moving some of our capital acquisitions up in the process. So if we had ventilators that we were going to order this year, we moved them all up, ordered them at one time, patient monitors, hospital beds, and what we've done with those, instead of delivering them directly to the hospitals that are supposed to be getting those, we've staged them at a central location, inventoried them, tested them, got them all ready. So they're staged at a central location. So as if we see things pop up from a surge perspective, then we can deploy those out from a central perspective. And then once this is over with, regather them and bring them back to the hospitals that actually were getting that capital equipment.
That's great. Now, how are you tracking, like, for, I guess this is also an open question, like how's everybody tracking where all this equipment is going, and, you know, who needs it and where is it going and when do we get it back and all of that sort of thing? It seems like that's a logistical nightmare a little bit.
Yep. So when we're inventorying that, we're putting it into our maintenance management system with a location of the central depot or wherever it's at. And then once it's deployed to a facility, then that location changes to that facility, as well as on some of the equipment, we're tagging it saying, we've got a hospital that's opening in Spanish Fork, Utah, and we're using some of that equipment. So we're tagging it saying that this device actually belongs to Spanish Fork Hospital when it comes out of use. As well as, you know, we're participating in the White House's initiative to have designated ventilators that are made available to potential hotspots. So we've generated that list with our asset tags and equipment that we've provided to the federal government saying, if you need these, here's what we've got that could be available. So it's tracking that as well.
Great. Thanks, Mike. I did read that. That's an interesting initiative there. Okay, anyone else?
Yeah, Heidi, this is Bill Manis. What we've been doing with assisting these states and stockpiles and such is assetizing it, pretty similar to what we do with our rental fleet equipment, and tracking it within our system so that we know where it's at, what kind of maintenance might be due or when it's going to be due, so that when they do start bringing it all back, that we'll be able to segregate it and make sure that the maintenance and it's patient ready for the next time it needs to go out. So pretty similar to how we manage our 400,000 pieces of rental equipment across the U.S., just kind of applying it in a smaller location setting.
Okay, thank you. Okay, John, you actually kind of touched on this, and this question is to the facilities representatives here on the panel. A lot of the COVID-19 national discussions have been around having enough ventilators and PPE, but have there been any concerns or capacity planning regarding equipment or utilities that facilities typically manages? And what challenges have you faced with this?
I think our biggest concern has been around the availability of oxygen or medical air to power ventilators. Our engineering staff took a good hard look at the ability, the sizing of our systems, the ability to deliver air or oxygen to every location that it was intended to be in the volumes that we would need if we had to run ventilators. We've determined that we are in good shape as far as utilities to support the COVID response. The question that we're now noodling for the future is, how do we build this ability into more of our facilities, or how do we make this ability to provide medical utilities available outside or off-site? It's going to be an interesting problem to solve.
So Bob okay here, I'll jump in on that too. I mean, I'll echo the O2. That was a huge issue. I run 3 sites. My mid-sized site, which is about a 350 bed hospital, the evaporator was icing up pretty regular. We had to get that corrected. The bigger concern for the staff, though, and moving forward as we were expanding, is do we have enough negative pressure areas? And the answer obviously was no in the beginning, but we were able to get creative and, you know, add additional rooms in as we went through. Some things as simple as taking a window out and putting a vent out the window. You know, sounds silly, but the amount of anxiety that was relieved by the clinical team was huge as we kind of developed on the fly what we were going to do to try to make areas negative. So that was a huge problem for everybody as this thing just steamrolled through New Jersey.
Heidi, this is Derek Watson with University Health.
Go ahead, Derek.
We had some pretty interesting, ingenious ideas initially. We actually took 8 of our 18-bed units and we made them completely negative by installing negative air machines and pumping the air out of the unit. So basically we had 8 negative pressure 18-bed units that we put anti-rooms on and put up protocols and systems in place to be able to do that. We've since then been able to back off of those a little bit, but we were able to block returns. One of the challenges we've run into, though, is the cooling. It is gotten warmer here in Georgia, and the ability to keep some of those units cool with 100% exhaust has been challenged. So we've really had to come up with some creative ways with that. And then just last week, I was asked to, we have a hospital that really is underperforming and hasn't been used in a lot of areas. We're actually converting the hospital that's basically empty into ability to do infectious disease control. And we're going with 100% OA and 100% exhaust for 14 of the initial rooms. And I think we'll continue to move that forward. So we're doing some renovation work by doing that. But cooling as we get into these hot months south is going to be a challenge for us.
Interesting. So Derek, mentioning that hospital. So how are you having to work with HTM and IT to get that hospital up and going in kind of a new capacity?
They are at the table on a daily basis. So cabling was old. We've had to work. We get to work with IS to help us. We've got to rerun. We've got nurse call. We've got telemetry, and we have IS data that we have to rerun. We've had some amazing vendor partnerships and been able to collaborate even with 2 contractors coming together at the same time, working in the same space. I was able to garner 60 negative air machines right at the beginning of this and hang on to them, but I've got all 60 negative air machines running throughout different facilities we have here to help with the control of the airspaces. So it's been a lot of fun. Our first containment unit took us about 7 days. We actually ran ductwork down the hallway and pretty cool, but we got it down to about 3 days. And IT, along with Biomed or HTM, has been right alongside with, we need a drop here, or we need workstations on wheels. We went into all of our ORs because we shut down all elective cases basically, and we got all of our equipment out of the ORs. And that took a lot of effort from our HTM folks to repurpose those and get those into the patient rooms where we need it. So it has been an amazing, from my perspective, it's been an amazing collaborative effort across. Everybody put everything aside, and we have focused on what the patient needs are, and everybody has dropped everything to get there.
Great, thank you. So Joey, I'm going to pick on you for a second. So we're hearing a lot about an uptick in cyber attacks during this emergency. Why do you think that is, and how is your department collaborating with HTM and facilities to protect their OT devices?
Yeah, so like just about any crisis that ever happens in the world, it creates an opportunity for a lot of threat actors out there in the world. A lot of most of those threat actors are usually your individual actors, your guys sitting in a coffee shop somewhere, not very technically savvy in and of themselves, but they just either through automated phishing attacks or things like that, they altogether that creates a significant threat landscape or an increase in our threat landscape than it normally would be. And COVID is no different. I think phishing is definitely the biggest, or at least the most notable change in the security landscape with all of it. We're seeing a significant increase in email-related phishing attacks with the emails stating that there's some miracle cure or that there's a vaccine potentially available, or sometimes it's more innocuous, such as reports of like the latest metrics of what's going on with the outbreak. But in any case, all that, as hard as we try to filter it out and as hard as our vendors try to automate that, it's an ever increasing number that daily struggle that we fight against. With how we're trying to handle a lot of the risk that's out there, or how we're handling the changes in our landscape, in addition to a lot more monitoring around phishing attempts, we also, our organization, we took advantage of, sounds kind of weird to say it this way, but there was an opportunity to open with a lot of people working from home, like the mass exodus of people working from home. And so we decided to rapidly expand and upgrade our remote access infrastructure, starting initially with a lot of our administrative and non-clinical staff, but now we're also looking at expanding it, or we are expanding it to a lot of our vendor support, vendors, as well as contractors, and we're continuing with that effort as well. From the operational technology side, a lot of it has a change from where we were doing before, other than the increase in network monitoring. I'd say a lot of the efforts on that end have probably been obviously with shifting prioritizations. A lot of the change has been the temporary shift away from some security work and remediating some security risks that's out there, so that we can address this greater operational threat within our environment.
Okay. Thank you. Okay, now this question is directed to Mike and John, since you both work at Intermountain Health. On March 18th, soon after the COVID-19 pandemic became a major concern for U.S. hospitals, a significant earthquake occurred near Salt Lake City, Utah. What response was required of HTM and facilities after that earthquake, and how did you determine priorities amidst with everything else going on there? And what tasks required your departments to work together?
Good question. We've been working closely together for years, and we recently, it's not so recent anymore, about 3 years ago, started to move toward a shared service arrangement for facilities and for clinical engineering. When we experienced the earthquake, it was really just another day for us at work together. The clinical engineering team really became an extension of our facilities management eyes and ears. They work in all kinds of places in the hospitals, and as they went through, they reported their observations. Any damage or disruption, they called directly to the hospital facilities team. As a part of their daily work, they pay close attention to some systems that they don't directly manage, like medical gas and electricity, but they use heavily. And so they know what normal looks like, and they were able to report those abnormalities very quickly. They did a great job for us.
And Heidi, I want to echo John's comments a little bit, and as well as say, if you want to make things interesting at the start of surge planning and expansion and things like that for a pandemic, throw a 5.7 magnitude earthquake in, along with two 4.6 and a 4.2 aftershock, and things get real interesting real quick. But in agreement with John, and we've been working together for some time, and we did work together to assess possible damage to equipment, facility, supplies, anything along those lines. We met together. Our teams worked individually first, and then across the spectrum of facilities and equipment, and then really to identify any issues, anything that needed to be escalated up the chain. And then really it's a mentality of our organization and within our own departments is it's not a them and us mentality. It's more of a one team, one mission. And I think that's how we really got through all of that.
Yeah, it's amazing, honestly. Great job. So I'm going to kind of switch gears a little, moving away from the COVID-19 questions to more general questions. And I also wanted to take a moment to let the audience know that we'll be taking, kind of opening it up for questions towards the end, the last 15 minutes of this webinar. So if you do have any questions, please type them in now and we'll open it up to the panelists as well. So kind of switching to some more general questions then. What has changed, and this is for everybody, by the way, what has changed over the years that now requires IT, HTM, and facilities to work more closely together?
Hey, Heidi, this is Danielle Cowgill. I'll actually take a stab at that. With Stanford Children's, we've been doing a lot of work with all three groups, especially around integrated care. So for example, a lot more equipment has been more integrated than ever before, especially systems that may not seem to need data flow between them. For example, our ventilators send information through our patient monitors into the patient record. Because of this, we have to have a lot of availability of port and wireless. So all three teams have to be able to work together in order to have that data flow seamlessly. Also, clinicians and clinical staff don't have time to stop and think, whose problem is this? They just put in a ticket and it's our responsibility in order to assess the situation, troubleshoot, and triage where does that need to go and how can we best work together in the background to not interrupt clinical flows.
Thanks. Would anyone else like to take that one?
Yeah, and I think, Danielle's right on target with that. And we start talking about, when I started in this field 30 some years ago, if you look at it, there was a clear defining line between, between responsibilities when it came to medical equipment, facilities operations, IT departments. There was a clear-cut line in that. But as technology has progressed, and you look at the integration of equipment across all spectrums, and that includes automated work requests coming through different avenues and different areas, where the equipment connects to, what it needs, and what's required. It's no longer a who owns what mentality. It's more of a collaborative effort now in saying, if we get called up on a call and we look at it and say, we need assistance with this. And Danielle's right. It's no longer, we don't need to get the clinical staff involved in it per se anymore, because what we need to do is make sure that we're all working towards the same end, and that's providing the best possible care to our patients and our consumers at the highest quality.
Okay, thank you. So these next two questions actually kind of go along with this one, but I know it's one that I personally struggled with when I was in HTM, and curious what you have to say about it. So every hospital has those systems and assets that seem to fall into this gray zone. There's really no clear line of responsibility. Systems like nurse call, should IT, facilities, or HTM manage it? Servers that are part of clinical device systems, is it IT, HTM? Beds, again, they're becoming more and more smart. So who's supposed to be maintaining those? So what does your hospital, how does your hospital decide which department is responsible ultimately for what? And, what are those challenges also? Just kind of trying to figure out, who has what.
So this is Joyce Smith. So the way we decide upon it, especially with newer assets coming into our organization, is that most, if not all of our domains, particularly on the ITD side, but that also includes like lab IT, nursing, informatics, clinically facing IT departments. They have representative, either BR, business relationship managers, BRMs, or enterprise domain architects. And those are individuals that basically are representative for those different organizations or those different departments. And they're the ones that, they're the meeting of the minds when they get together for, let's say, new assets coming in. And they're the ones that really try to answer those questions and get that delineation. For existing assets, it's kind of it's as that process goes forward for the new assets, it's kind of helping set a baseline, at least to some extent, for what we can do about our existing assets, to where that question does routinely come up whenever we on the security side say need to go through an effort for remediating vulnerabilities on an asset. Sometimes we get into the problem of, there's the business owner, and the business owner is a clinical department. Then we get into the IT owner, and it's usually someone that's in radiology, or RAD IT. And so, we're trying to get that more ITIL, like ITIL focused, that ITIL defined breakdown of the services provided for a given equipment or given application. And we're trying to define that more within our workflow and asset management tools.
Okay, thanks, Joey. Anyone else want to take that one too?
Hey, Heidi, this is Danielle, Cowgill. So one thing that's different at Stanford Children's is that our clinical engineering department actually reports up through our IS chain of command. So our director reports directly up to our CIO. So because we are part of the same department, there stops a lot of that delineation. And our team has actually taken a bigger role in supporting servers, supporting some of those systems that used to traditionally be more IT based. We kind of go based on if it has anything that's therapeutic, if it really touches the patient, then it's something that biomed takes lead on. We frequently will bring in other teams as needed. So maybe we need some support from our network engineering team, traditionally the more IS based, or we deal with the booms in our ORs, which a lot of groups would have their facilities teams take lead on. However, because they are so integrated, we kind of take the lead to bring those two groups in together in order to try to bridge that gap more easily and kind of give one source for people to go to in order to better problem solve.
Great.
And Heidi, we do. If John Ellis isn't going to toot his horn here, I will, because we got together as a team, and we put together that gray area list of all equipment, put it all together, and then we meet as a team and say what should go where, what should lie with who, and we do assign a primary department that's responsible for that. But again, it's more of a collaborative effort, saying yes, you're the primary on this. But if we get a call on this, we're going to approach it, and then we're going to bring in those that are necessary. And I approach this with my staff from a clinical department perspective. If you present at the ER and they take you to a room and they go, you know what, you got heart issues, I'm not a cardiac person, you're going to have to wait until they respond. That doesn't happen in clinical departments. People do what is necessary on the spot at that time, and then they bring in the experts that are needed, and I think that's the way we approach it here from our facilities. And again, John is a big part of that in our facility.
It's been a great joint effort.
I can feel the love here. It's great. Okay, well, I think at this point in time, I would like to open it up. If I do have more questions, but I do want to give the audience some time to answer some or get their questions asked and answered. So Linda, do we have any questions from the audience?
Yes, we do. We have a couple. There's one question here that he said is directed to anyone. Everyone always talks about what they will change because of learning from a situation like COVID-19. Is there any process that you set up recently prior to COVID-19 that you couldn't imagine not having through this crisis? Anybody want to answer?
If I'm okay, I guess I'll jump in on that. That's a good question. It's a great question. I guess moving forward, this crisis is going to change some of the building codes and some of the requirements. And I go back to, isolation. What does that mean for a facility to isolate a patient that's, positive? And that's a challenge. And I think it's going to be a challenge moving forward. And we need to try to figure that out on the fly, unfortunately. But that's a big problem.
Anybody else?
I'll let somebody else go because I feel like I'm talking too much. People want to hear from me, so I'll let them.
Would anybody else like to answer that question, or do we go back to Mike?
I think one of the things that I cannot imagine succeeding through this without is a robust preventive maintenance program in place before this happened, knowing the state of our equipment, the state of our facilities, and feeling confident already in our readiness to respond to whatever healthcare brings us. It doesn't have to be a pandemic to be a disaster if we're not ready.
Okay, following on from that, actually, what new pandemic processes do you think you will carry over?
This is Bill
One of
Mammoth.
the things that, oh, go ahead, Bill.
Okay, just real quick, from a third party, what we're seeing is that you're going to see more and more healthcare facilities really collaborating and sharing of equipment and having like a central depot where they can pull from and logistically get to other parts of their system so that they have the equipment ready ahead of time, not waiting until something happens. I think you're going to see healthcare systems being more collaborative and more proactive in really having that equipment ready and being able to be shared within the systems. Because you're seeing that also at a state level.
Yeah, that's exactly what I was going to say, Bill.
Okay, so we have a cybersecurity question here. With regards to cybersecurity, what social engineering risks have arisen due to COVID-19?
So this is Joey. By far and away, the most prevalent one is email, because it's probably the most easy and automated one that an attacker can use. That said, it's all the same classic social engineering tricks from basically anything else. So email is probably, again, the most prevalent, but occasionally there's a lot of spam calling. Some, especially probably more sensitive organizations or maybe high profile organizations, may have to worry about the risk of USB drops or infection from, let's say, a third party vendor. But I'd say in general, there's no change really in, I'd say, the landscape of social engineering with regards to COVID. It's just that there's a lot more COVID-related phishing attempts out there.
And I think, just to echo a little bit what Joey said earlier in the presentation and talk and stuff, is that, here at Intermountain Healthcare, we employ 40,000 people across the state of Utah and Idaho and Nevada. And when you start looking at it, the latest number that I heard from our organization, we had over 10,000 that were working remotely from their homes. And I think that poses another whole new situation and ballgame for organizations as well.
Okay, this is a question for anyone. Do you anticipate a surgery surge? And if so, what is your plan if that does occur?
If I'm okay, I'll jump in on that. I mean, I kind of addressed this before. We definitely anticipate a resurge. There's no doubt. And now, as we kind of get back to regular business, what do we dismantle? What do we keep in place? Knowing that our ICU volume, especially, can surge up. And from the facility side to the IT side, what do we keep in place and what do we dismantle? And then if we do dismantle, how quickly can we put it back together and handle the surge that we're going to see? So we're putting that together now. I don't have the answer for it, but we're trying to figure out what does that look like moving forward.
And I think, as well as here at Intermountain, when we're talking about a potential surge as we reopen elective surgical cases and people start coming to the hospitals, one of the things that I think we're facing here, and I would anticipate that other healthcare systems are facing the same thing, it comes down to PPE again. Because we're utilizing a tremendous amount of this PPE for the pandemic and the surge, are we going to have the available stock and what we need when it comes to surgical gowns, surgical procedure masks, and things like that to handle that elective surgery surge along with the pandemic piece?
Okay.
This is Danielle. We're also trying to prioritize how do we handle the surge and in surgical cases, how do we prioritize those patients over if there is a surge with the pandemic as well? So one thing we've been trying to do is make sure we could flex up rooms for ICU, and also that our discharge practices are better, and that our outpatient clinics can support these follow-up appointments, which patients used to come to the hospital for, trying to get more patients to go to outpatient. So trying to essentially kind of stock up our outpatient clinics to take on a little more of the load that the hospital used to maintain.
Okay, we have a question for anyone that would like to answer. You are all from progressive organisations. What concerns would you have if you had to draw upon a national central repository stockpile of medical devices that came from numerous sources?
So one of the things that I think that we've already seen in drawing from those national stockpiles is the condition of that equipment that's coming out of those stockpiles. How long has it been since they've had a PM done on them? How long has it been since they've actually been powered up and tested? How long has it been since they've been used on a patient? And then when you've got that number of devices coming out of a national stockpile, who's the responsible party for bringing those devices back to an operational and functional status? And do we have the team, the availability of team members in those areas where that stuff is coming out of to be able to do that along with handling the day-to-day operation and things that are going on within the facilities?
Okay, does anybody else want to answer that question?
This is Joey. From the IT side, I think one of the biggest worries that we have is, well, I guess kind of two worries there, is when that equipment is being, I'll say, quote unquote, acquired for use in our organization. I would say there's a gap more in, say, a potential gap in organization processes, because it may not necessarily be treated as a new asset coming in. So it could be something that falls through the cracks in our existing processes and may not go through the proper security and IT assessment processes. And so we may be bringing something into our environment that was at a previous facility, and at that previous facility they had, let's say, a dormant virus outbreak, and all of a sudden that virus could be stuck on a device, could be stuck on, or maybe it's there's a USB drive that came with the device and the virus is dormant on that USB drive. And all of a sudden we bring that into our organization and it doesn't go through our proper channels, then it creates potentially a significant risk to the organization.
Okay, well, I'm going to pass back to Heidi now. Heidi, have you got any last minute questions you would like to pose to the panel before we wrap up?
Yeah, I do. So kind of getting back to our original, the title of our webinar today about, working together between the three departments, and I'm just going to put all of you kind of on the spot. So I'm going to start with the HTM panel. So what challenges do you have working with IT and with facilities, and have those challenges increased or decreased in recent years, and why? And I'm going to ask each group here. So since we have 5 minutes, make it brief, please.
Okay. So Heidi, I'll try and make mine real brief, and that's, I think that the challenges have decreased over the years, and a lot has to do with the crossover of responsibilities. It's equipment integration, it's equipment connection, and then throw the cybersecurity threat in there, and it has required the departments to work closely and work together more often, which has decreased those challenges.
Okay, how about the facilities team? What do you think about working with HTM and IT? Have those challenges increased or decreased, and what are you seeing as far as collaboration?
This is Derek with University.
I would say that the collaboration has been phenomenal. Any barriers that were there got broken down immediately once the pandemic rolled into New Jersey, and we started making things happen. And there was no issues at all. The collaboration has just been phenomenal within the organization I work for, and everybody rolled up their sleeves and just made things happen. And at the end of this, I think that will last, and everybody knows how important between IT, facilities, and the cyber side of it is to work together, and it's been identified, and it just kind of all came together quickly, and I think that will last moving forward.
IT is certainly its own animal, and they have their own mission, and like the rest of us, tend to live in a tunnel vision world sometimes. I've found that as I've taken the time to explain how their work interacts with and can affect our life safety systems in particular, IT has become a greater ally than an adversary that they may have been in the past. And as they understand at the front line how their work affects patient safety, they really spend a lot of time and attention getting their work right, and then notifying us of problems that they may find that they didn't create, but they've noticed in the course of their work. So it's as Mike said, over the years, it's gotten a lot better.
Okay, so Joey, I'll toss that one over to you then. But what challenges do you have working with HTM and with facilities, and have you seen those challenges increase or decrease in recent years?
So this is Joey. I would say that the number of challenges have not increased over the years, but I think as we've become more, we as an organization, as well as we as in the broader industry, as we become more mature about our problems, the scope of the challenges increase. And so we're starting to become more aware of the things we need to do, the actions we need to take, the outcomes we want to get out of that, and how do we, one of the biggest challenges we have internally right now is, for example, how do we measure results and outcomes for securing our devices? We can't use standard metrics IT uses. We have to use some different set of metrics that are more reflective of the reality of medical devices, just as an example. So I think as we continue to go forward, with a lot of that understanding will mature, and it'll increase again. I think more the scope of the challenges, but at the same time, it's going to decrease the amount of challenges that we're having.
Okay, well, thank you. First of all, I want to just take a moment to thank the panelists for volunteering to be part of this panel. It has been an incredible, as far as I'm concerned, it's been very, very informative, and I think our audience, I'm sure, has also found it very refreshing to hear, the changes over the industry over the years, and all the things that all of you are doing to work together and collaborate. Linda, if people do have other questions that they want to direct to the panelists, how would they go about doing that?
They can send it to us at webinar@mdpublishing.com, and we will certainly forward any questions we receive to you or any of the panelists.
Okay, great.
Okay. Great.
We'll wrap it up.
Okay, thank you so much, Heidi, and obviously to all our panelists as well. I agree with Heidi, it was a great and informative webinar. We'd also like to thank today's sponsor again, Nuvolo. Just a reminder to attendees that the post-webinar survey and certificate process is automated, so the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information about all our upcoming webinars, please visit our website, webinarwednesday.live. Thank you once again for everybody to join us. Enjoy the rest of the day, stay safe, and we hope to see you next time.